Hi, this is Dr. Bernstein with our January 2020 teleseminar. Before we get to any questions, I want to tell you about a phone call that I received last night from a mother of a 14-year-old type 1 diabetic asking me to help her in a battle with her doctors. She boasted that she put her daughter on a low carbohydrate diet and took her off insulin for 20 weeks. And now she's in the hospital with diabetic ketoacidosis and a blood sugar of 400. Now, the first thing that occurred to me was, how on earth could a mother allow a child to have a blood sugar of 400? And why on earth would a parent take a type 1 diabetic off of insulin? Now, I could only guess, because I've spoken to many people over the years who took their kids off insulin, and there are several reasons. One, they look on insulin as a stigma, and to be injecting needles all day long is something bad. Well, it's keeping them alive, and it's absolutely necessary. Another reason is that the myth that if you can be off insulin for a while, you can stay off insulin, which is just the opposite of the truth. This will, taking them off insulin is going to result in higher blood sugars, which will destroy beta cells and make the diabetes more severe. So if you have a new onset diabetic, you want to preserve beta cells and not take them off insulin. Now, yet another reason is that the many endocrinologists advocate not prescribing insulin for patients until their beta cells are burned out. They tell the parents, your kid's in the honeymoon period, wait until their beta cells burn out, then we'll put them on insulin, which is absolutely the wrong thing to do. You want to preserve beta cells. On top of all that, this mother mentioned that her daughter had lost a lot of weight. Of course, she was metabolizing her own body fat and protein, literally digesting her own body because she did not have enough insulin. So I certainly was not going to attempt to do something long distance with a child I had not seen, had not examined, etc. And I told her that, and I suggested that she read my book, and that was it. But it's a sad situation. Now we're going to take a look at the latest issue of Diabetes Care, published by the American Diabetes Association. I should say the December 2019 issue. There were several articles that I considered of concern, and as usual, the conclusions that I drew were different than the conclusions that the authors drew. When you read a scientific report, you should look at who supported the study and where are the authors getting their income from, because all too frequently, that's what determines the conclusions they're going to draw. So let's see what we have with the first article. This is a comparison of a sulfonylurea glimepiride to a DPP-4 antagonist called liragliptin. Now, the DPP-4 antagonists are used for type 2 diabetics, as are the sulfonylureas, but the DPP-4s have very little effect on blood sugar. They're almost useless. The sulfonylureas, while they're acting, have a very strong effect on blood sugar if there are beta cells still remaining. If there are no more beta cells, then the effect is minimal. Now, so you're comparing two things that are totally different. And in this case, they're comparing them for cardiovascular harm, because for years there were studies of sulfonylureas that claimed that they caused cardiovascular disease. And there were good biochemical reasons for suspecting this, but this latest study, which was a large one, looked at cardiovascular disease after an extended period of use of the lisagliptin versus the glimepiride sulfonylurea. And here they're reporting that there's no cardiovascular harm. But they totally ignore the fact that the sulfonylureas force the pancreas to make more insulin, thereby burning out beta cells. It's been known for many years that the sulfonylureas are good for maybe 1 to 3 years, during which time they cause beta cell burnout. So why on earth would you want to give a sulfonylurea to anyone? Why do you look for cardiovascular harm when you shouldn't even be using the product? Well, if you look at the author's sources of income, you'll see why. Here's another one from the December 2019 issue of Diabetes Care. 1 year clinical experience of the first commercial hybrid closed loop system. This is the Medtronic's combination continuous glucose monitor with an insulin pump. And this particular article, this was approved by the FDA in September of 2016, and now here's a post-approval study of how it fared over the course of a year. And this article is boasting about great success, but when you look at the A1C before and after, you see that with this system, it dropped from 7.7% to 7.6%. The super artificial pancreas lowered A1C by 0.1%. And if you include the uncertainty in each of these, the numbers totally overlap. So they're claiming a statistically significant difference in A1C and boasting about it. That difference between 7.7 and 7.6 is about 4 milligrams per deciliter of blood sugar on average. And again, you can guess on the sources of income of the people who published the study. I might point out that there was no study of the creation of scar tissue, and the usual problems associated with insulin pumps. Another article from the December 2019 issue of Diabetes Care. Incidences of severe hypoglycemia and diabetic ketoacidosis and prevalence of microvascular complications stratified by age and glycemic control in the U.S. adult population with type 1 diabetes. Well, what they found is something that's been demonstrated in type 2 diabetics previously, namely that the higher the A1C, the more frequent the incidence of severe hypoglycemia. So here we have an ADA journal which is challenging the ADA point of view that blood sugars of diabetics should be kept high in order to reduce the incidence of severe hypoglycemia, where in reality, a study in their own journal is showing that the rate of severe hypoglycemia, in this particular case, I believe it doubles for A1Cs above 7%. So you double the rate of severe hypoglycemia when you increase the blood sugars. It just doesn't make sense what's being advocated. Now, here is something that explains things a little bit. The cover of a recent issue of Medical Economics. And what's the headline? Malpractice Defense. And we know that one of the major reasons for doctors to adhere to guidelines in their treatment of patients, even when the guidelines are unreasonable and make no sense, because of their fear of lawsuits. They say to themselves, if I stick to the guidelines, I can't be sued, even if the guidelines cause harm. Whereas if I don't adhere to the guidelines and the patient is in better health, my chances of being sued are reduced. So this is something that I run into with physicians all the time. We know about recent guidelines, especially with the treatment of diabetes, advocating high blood sugars, high carbohydrate diets, and so on. Now we'll get down to our questions. Before I answer any questions from patients or relatives, I remind you that my answers are generic. They can't reasonably apply to the person who asked the question because I haven't examined them. I have for diabetic complications. I haven't gotten a full medical history and so on. But I'm trying to educate the large group of listeners, and it's to them that my answers are directed, really. I love popcorn. After lunch, my blood sugar is usually 120, but after popcorn, 265. Somehow, I could eat my favorite food. Any ideas, suggestions on what to do about my current doctor who thinks I am normal and not diabetic? Well, I guess it's possible to bring a non-diabetic person's blood sugar up to 265 if you eat enough popcorn. I have no idea how much popcorn this person ate, and it could be that she's not diabetic and ate a huge amount of popcorn. It also could be that she's diabetic and ate a small amount and her blood sugar went up to 265. So there's no way that I can tell, and I don't know what to do about her physician who says she's not diabetic. I don't know it myself. Type 1 diabetic for 2 years, 40-year-old male. Red book, follow regimen. Endo refuses to prescribe me human insulin, says it increases likelihood of hypos as it stays in system longer than NovoRapid. Well, if NovoRapid is the same as Novolog, that's true. It does last longer, but it's more appropriate for covering, for example, meals where you're on a low carbohydrate diet. Now, this doctor probably wants the patient to be on a high carbohydrate diet where he needs an insulin to work very fast to cover the carbohydrate. The trouble is that on the high carbohydrate diet, you don't get predictable results. You get too much variability. And you're just guessing at the amount of insulin you need. On top of that, the NovoRapid is 50% more potent than human insulin, so it's harder to measure if you need only small doses. This person says A1C down to 5.7%. Doctor says A1C should be at least 6.5%. Says a type 1 diabetic should not expect blood sugars to get any better. Won't listen to my reasons for switching to human insulin. Won't believe the research for low-carb diet. Next appointment next month. If he still refuses, what can I do? Well, it really depends on whether your insurance requires that you have this doctor. In the USA, there's a big insurance company on the West Coast that requires that you use their doctors, and their doctors tend to be advocating guidelines rather than common sense. And if that's the case, what you should do is have your lawyer send a registered letter to your doctor's office requesting a copy of your medical records. Now, that will worry the doctor's office and the insurance company that you might be considering a lawsuit. And that might get the doctor to change his tone. So that's one possibility. If this is a doctor that you have selected and that you can change, the game plan is to find a new doctor. You could tell him that if this is how you're going to treat me, I will find another doctor. But you should have the other doctor lined up first before you say this to him. How do you find another doctor? Well, if you have friends who have a family care physician whom they like, you can visit that family care physician in advance and see if he'd be willing to write prescriptions as per your request. And then you can approach your existing doctor knowing that you can make a switch. Plant-based protein. What are your thoughts? Well, um, there may be some non-diabetics who can tolerate the carbohydrate that's going to come with the plants in order to get the little bit of protein that they're going to provide. There are very few plants that have a lot of protein. Even soybeans would require you're eating a lot of them to get enough protein to meet the usual human needs for protein. So non-diabetics can probably get away with it, but I doubt that diabetics can rely on plants as their only source of protein. How do you record carbs ratio for insulin? That's a big mistake. What this person has just told me, in effect, is that he or she wants to continue to follow ADA guidelines, eat different meals every day, eating a lot of carbs, and trying to cover the carbs with a lot of insulin. You follow the guidelines in the book. You have consistent meals from one day to the next, so that once you've worked out the amount of insulin for a meal and the timing of the insulin when you take it relative to the meal, you keep the meal the same every day and the insulin regimen the same. Jumping around different carbohydrate foods every day, you're never going to get it right. Now, if I have a patient who's not insulin resistant, but not making any insulin, that is a full type 1 who's not obese, not insulin resistant, doesn't have polycystic ovarian syndrome or any infections, I might start off with 1 unit of insulin for 8 grams of carbohydrate, slow-acting carbohydrate as in vegetables, and reduce that by maybe 20% in working out the first meal. And then look at the results. Why do I reduce it? Because I don't want to overkill, and we'll see what happens to the blood sugars. We can always correct the blood sugars if they go too high. It's all covered in the book. So read my book, Diabetes Solution. What are low carbs options that are high in potassium and chloride that are important to restore electrolytes during sickness? Well, this is a situation where you have diarrhea or vomiting and have lost a lot of fluid, and you want to replace your fluid, but you don't just want to replace the water, you want to replace electrolytes. Well, we have a product in our local supermarket called Power Light Zero, which has no carbohydrate and has a nice balance of electrolytes. There's also Gatorade 0 calorie, which has no carbohydrate. Just check the label of these electrolyte solutions that you could usually buy in drugstores or supermarkets. They come in various size bottles. I think that we get an 8-ounce bottle, but they also make, I believe, a 12-ounce bottle. And you might even be able to get 32-ounce bottles. Is Tagatose any better than other sweeteners? Well, it's 38% as effective as table sugar on raising your blood sugar. So if you were previously using table sugar to treat hypoglycemia, you'll need almost 3 times as much of the Tagatose. I certainly would not use it as a sugar substitute, as a non-caloric sweetener, because it isn't non-caloric. And for treating hypoglycemia, I would use pure glucose, not Tagatose. It's probably slower acting than table sugar, and certainly slower acting than glucose. Thoughts on CBD oil, that's cannabidiol oil. It has no impact on my blood sugar, but improves my sleep. Is it safe? Well, you're asking the wrong guy. I'm not an expert on addictive substances. I have read a lot recently about problems with CBD oil, especially contamination, where since this is not approved by the FDA, it's being sold illegally in most states, and therefore there may be any kind of contaminants, hormones, poisons, arsenic, metals, heavy metals, etc. But I'm not the expert, so you have to contact an addiction specialist or maybe a poison specialist. Want to make sure I'm interpreting correctly. Theoretically, I could remain compliant with your program while eating 4 meals per day, for example, and he lists a meal at 6 a.m., 11 a.m., 4 p.m., and 9 p.m., all 5 hours apart from one another, and having a maximum of 12 grams at each meal except breakfast with 6 grams of carbohydrate, and he's taking protein scattered throughout the day. So he has a total of 42 grams of carbohydrate and 17 ounces of protein for a day. And this might work. The closest I've ever come to prescribing this is for children who require snacks in between their meals, where we have to cover their snacks by small amounts of insulin, like fractions of a unit of insulin. So I've never given this sort of meal plan to a patient, and I don't know how it'll work out. Maybe it'll work. So what Yogi Berra always espoused, what works, works. So give it a try, see what happens. Type 2 for 14 years. Wait. No, this is the same person. What are the guidelines for exercising with high blood sugar? At what point should you avoid exercising, both high numbers and low numbers? Well, it probably varies with the individual. If I had to make a general rule, I would say 83 to 150. Below 83 for an adult, if you're going to be dropping from the exercise, I usually, by the way, get mine up to 90 before I start, because I always drop. And I repeatedly get it to 90 during my workout. Above 150, most people would see their blood sugars going up. You become insulin resistant as your blood sugar gets higher, and you do need a certain amount of insulin to cover your exercise. so that your blood sugar doesn't go up. Okay, let's see what else we have. What are your thoughts on immune stimulators and vaccines for type 1 diabetics? I recently talked to an immunologist who strongly advised me against them as they might trigger another autoimmune disease. On the other hand, vaccines, especially the flu shot, seem to be promoted among diabetics by current guidelines. Well, I don't know of, there is one immune stimulator that is being promoted by one research group for supposedly preventing diabetes, but this research has not been successfully duplicated by other investigators. So I don't advocate any immune stimulator for treating diabetes. Whether it could do any harm, I don't know. But vaccines for preventing infections certainly are appropriate. So I recently had a vaccine for preventing shingles. That diabetics certainly should be given those. There are some live vaccines that I cannot take because I have an immune deficiency that's totally separate from the diabetes. So you don't want live vaccines if you have an immune deficiency. But if you only have diabetes, no immune deficiency, all of the vaccines that other people get are appropriate for diabetics and should be gotten. That includes polio, measles, pertussis, pneumonia, etc. What do you think of the Vigo wearable insulin delivery device? I am using it, and except for when it falls off or if I eat too many carbs, it keeps my blood sugar in check. Well, I don't know whether this person is a type 1 diabetic or type 2 diabetic, and I don't know what in check means. But this device can deliver a basal insulin dose that's much more than basal. It's 40 units per day, which is much too much for the average individual. A non-diabetic who is making her own insulin, and let's say she weighs 150 pounds, may make 25 units of insulin a day. This thing is delivering 40 units that they call basal, but that's going to force the person most people to be eating all day long to cover the insulin. And as far as basal bolus doses for covering meals, the bolus doses of this device are 2 units. So it means you could give 2, 4, 6, 8 units for a meal, but you can't give 3 or 5 or 4.5 units. So it certainly is not appropriate for type 1 diabetics. Now, if you have a type 2 severely insulin-resistant diabetic, there may be ways to make this work, but it would be pretty tricky. What is your opinion on continuous glucose monitors such as the Dexcom G6 or other similar products? Well, I use a Dexcom G5. Some people prefer the G5, some prefer the G6. So if I'm using it, I certainly advocate it. And I advocate it because it will warn me of low blood sugars with an alarm. And there's a competitive device that gives no alarms, and that certainly is essentially worthless. So you could see my videos for tricks on using the Dexcom device, because there are tricks to using it, and I strongly advocate its use for anyone who's dependent upon insulin, type 1s, and I have a few type 2s who also use the Dexcom. What is your thinking on insulin pumps, especially now that pumps such as the Tandem work together with a continuous glucose monitor? Well, if you've heard the early part of my January 2020 discussion, a report on this Tandem monitor found that it only reduced A1Cs from 7.7 to 7.6. And if you're using an insulin pump, you're eventually going to develop scar tissue that gives unpredictable absorption of the insulin doses. So this initial study was only for 1 year. Just wait till they try it for 3 years or 5 years, and the scar tissue forms. There's also the long-term problem of abscesses that require surgical intervention. There's the problems with ketoacidosis when the pump has mechanical problems, etc. What would be an ideal daily menu to maintain level blood sugars? Well, read my book, Diabetes Solution, or the book Diabetes Diet, and you can find many suggestions of a general nature as well as many recipes. Where can I find a doctor that follows your guidelines to help oversee the insulin dosing and other care for our newly diagnosed 14-year-old daughter? Well, this is a real problem. Because the guidelines are so divergent from what I recommend, doctors are afraid to recommend normal blood sugars, low carbohydrate diets, and so on. On top of that, doctors don't have time to read. So how often are you going to find a doctor who reads my book, Diabetes Solution, to learn how to treat type 1 diabetes? It's a pretty impossible thing. I've encountered at least three type 1 diabetic doctors who use my regimen for treating themselves, but not for treating their patients because they don't have the time. So it's a blind alley as far as I can see it. And really it requires that the parent read the book carefully. If you have a 14-year-old daughter, she should read the book and understand it. And you should find a kindly family care doctor or pediatrician who will write the prescriptions that you need for following the guidelines in the book. You also could take a look at Type 1 Grit, Grit, on the internet, where there are several thousand people who are using my book, and they can give you advice. Would you recommend diabetics to participate in or avoid half marathons? Well, if, like I should say, most diabetics who are poorly controlled, they have neuropathy in their feet, I would recommend against it. If you're talking about a diabetic who's had normal blood sugars for many years, has no neuropathy in the feet, and has good vision, I would say that it's probably reasonable, but you have to be very, very careful and not follow the usual medical guidelines for marathoners, which are to load up on a lot of carbohydrate, which is not going to be helpful. We've discussed marathons in the past, and you certainly require frequent blood sugars and frequent use of liquid glucose to prevent the lows. What are some ways to treat nausea, cough, and vomiting as a diabetic? My physician couldn't find anything wrong. Well, my guess here is that this person is complaining of chronic nausea and vomiting and so on, which would suggest gastroparesis. And the one sure way to diagnose gastroparesis is with an RR interval study, which your physician probably doesn't know how to do. There is an article that's available on the internet, an article I wrote, published in Diabetes Care many years ago. A search will bring it up that tells you how to do an RR interval study. But most doctors don't have the time to either do it or to read the results. So it's hard to find a doctor who knows how to diagnose gastroparesis. A hint of gastroparesis would be frequent low blood sugars after a meal, followed by high blood sugars many hours later. And of course, we have a whole chapter on gastroparesis in my book, Diabetes Solution. Is there any new information on your idea that slim type 2s might really be mild type 1s? I don't think it's particularly important, because it's not the name of the disease that counts, it's the treatment that counts. You want to have normal blood sugars, and you do whatever it takes. Most of my type 2 diabetics are receiving insulin, and some of my type 1 diabetics are not just receiving insulin, but also receiving medications that are used to treat type 2 diabetes. So the treatment is what works. What works, works. So calling the disease by a name doesn't determine what the treatment would be. The treatment is whatever it takes to keep blood sugars normal. Why no exercise for 3 hours after arising? Is this true for both type 1 and type 2s? Well, it depends on the individual. I have patients who can exercise within 3 hours of arising and their blood sugars don't go up. But these are people who are making a lot of insulin. They're either newly diagnosed type 1s where we've managed to preserve their beta cell function, or their very mild type 2s who are still making enough insulin that the dawn phenomenon in the morning does not deprive them of insulin that they need to cover the exercise. There's one other possibility, by the way. One of my earliest patients, going back 30 years, could only exercise in the morning, and he took 2 units of insulin to cover his morning runs, and it worked very well. So this 3-hour rule may not apply to people who are making a lot of insulin. After the first hospitalized diabetic ketoacidosis event, how long would you expect the body to take to return to normal blood glucose levels, losing your protocol? Well, it's not the body that returns, it's the protocol that normalizes the blood sugar. For example, I had a new patient who was a young boy. He came in for his first visit, which was supposed to be training, but he was already in ketoacidosis with a blood sugar of 400, lethargic, etc. And somehow, this was many years ago, I had the guts to give him intravenous saline, IV insulin, get him rehydrated, get his blood sugars normalized, and we were able to get him on a regimen that kept him normal. That was basal bolus insulin right away. So it wasn't his body that all of a sudden changed. We all of a sudden put him on an appropriate insulin regimen and a low carbohydrate diet, etc., etc. Do you have any experience with hypnosis to help patients get control over overeating addiction? Yes, many years ago when I first started in practice. One problem is that not everyone is hypnotizable. Another problem is that not everyone who is hypnotizable can perform auto-hypnosis successfully. A third problem is that you have to perform it many times during the course of the day, certainly before each meal, and then probably at least once between each meal. So you're talking about a minimum of 5 or 6 times per day, and maybe as much as 10 times per day. So it is possible, but you have to be hypnotizable, and you have to be able to perform auto-hypnosis. There are some hypnotists who can teach auto-hypnosis. There are some hypnotists who claim that periodically hypnotizing an individual can keep him from smoking, and I would imagine that if that really works, it could probably keep him from overeating. Slim female, 67 years old. My blood sugars run from high 90s to a maximum of 120. A1C is 5.1, up from 4.9 6 months ago. Cannot get my family doctor to diagnose me as diabetic. What can be done? Well, first of all, if you're eating a high carbohydrate diet and your A1C is 5.1, that may be expected. That may be reasonable. You may not be, possibly not be diabetic. If you're on a low carbohydrate diet and your A1C is 5.1 and going up, then possibly you may be mildly diabetic. It's very hard to tell, so I can't give you a hard answer. If you are on a very low carb diet and following the guidelines of my book, Diabetes Solution, then I suggest that you find another family doctor who'll listen to you. But tell the other family doctor that your blood sugar is going up even though you're on a low carbohydrate diet. Do you have specific recommendations for type 1 diabetes management during matches for elite tennis athletes? Well, first of all, we do talk about exercise in the book. And I do point out in my book, Diabetes Solution, that high blood sugars as well as low blood sugars can both impair performance. So if you're competing, you really want to keep your blood sugars normal, and you want to take a break if you get high or low. So you have to find yourself in a situation where the people you're playing with or the organization that's sponsoring the match is cooperating with your disease. Now, I recommend that you use liquid glucose for treating the low blood sugars, and that you check blood sugars frequently, and also that you have use a continuous glucose monitor with an alarm. And these things will give you a warning if you have a fast drop, a rapid drop. So you can set it to warn you of rapid blood sugar drop, not merely a low blood sugar. That summarizes it pretty well. Do you still recommend soy flour, Da Vinci syrups, and Wasa light 7-grain crackers? Well, I don't recall recommending the soy flour. I still do recommend Da Vinci sugar-free syrups, and I have never recommended Wasa light 7-grain crackers. In fact, I urge people to consume slow-acting carbohydrate vegetables as their sources of carbohydrate rather than crackers of any kind, because we want to bring in natural vitamins. I also currently recommend Walden Farms sugar-free chocolate syrup, caramel syrup, and maple walnut syrups if you want to sweeten things. Sometimes I'll use one of these in my coffee or on a salad. They're very tasty. I was able to keep my diabetes in normal range without medication by being proactive. For the past 9 months, I've had to be on a steroid for an autoimmune liver condition. This steroid has raised my blood sugar to somewhere around 125, which is very high for me. Question is, what can I do to get my blood sugar back into the 80s like I had it? The steroid that I'm on may be a long-time situation. First of all, if you read my book, Diabetes Solution, we actually discuss this, and I give some suggestions for covering prednisone tablets with regular insulin. It turns out that if you're taking prednisone, the oral prednisone has a time frame that's similar to that of regular insulin. So there are ways of covering it. It does boil down to trial and error. If you're getting injected steroids, the time frame may be different. And again, it's trial and error. You might want to use long-acting basal insulin while you're getting the steroids. Again, depending upon the rapidity of steroid action, you might want to use rapid-acting insulin. It's all trial and error. You could read the book because it will tell you about the different insulins, and you've got to get a feel for the insulins versus the activity of the steroid. But it is possible to do something. And the only possibility I can think of is using insulin. I have very bad diabetes. I need to get it under control. I also need to lose weight. Do you have a guideline or plan to follow? I know you list what one can eat and what one should avoid. However, is there something more specific for weight loss available? Well, specific for weight loss is low carbohydrate. And there are some people who follow a low carbohydrate diet, but may eat out a lot and get fed huge amounts of protein at every meal. That could also foster weight gain and elevated blood sugars. I suggest you read my book, Diabetes Solution. Injectable Basaglar was given for insulin. After 4 months on it, my stomach became queasy in the night and feels much indigestion in the morning. Could the shot be disagreeing with me? I wanted Lantus to start with, but insurance claims it was not covered. Well, Basaglar is the same as Lantus insulin. So if this person is constantly queasy, it could be that he has gastroparesis. I can't be sure of that. He could have some other problem. Perhaps he should be worked up by a gastroenterologist. The problem with gastroparesis is the best way to diagnose it is with an RR interval study that we discuss in my book. But Basaglar is the same as Lantus insulin, so I doubt that it's the Basaglar that's causing the queasiness, if the Lantus previously did not cause queasiness. Even though I understand the diabetes solution principles with low carbs, with principal calories from protein and whatever fat comes with it, I would like to hear you talk about an ordinary day with insulins and food. I know that every individual is special, but I am sure that I would be inspired to hear about your ordinary day. Well, one problem with my ordinary day is that I'm working all day long and I don't take the time to have lunch. So I just have breakfast and dinner. And the other part of the problem is that I am lazy and don't like to make meals. My partner is not quite as lazy as I am, so she'll make a salad for me at dinner. Right now I'll have smoked salmon with cream cheese for breakfast with a measured amount of pistachio nuts that gives me 6 grams of carbohydrate. Actually 5 grams. I get 1 gram from the cream cheese. I have for dinner smoked salmon, cream cheese, cooked mushrooms, a salad, all to the tune of 12 grams of carbohydrate. I also have in there some avocado, getting to the 12 grams, and I have some smoked Gouda cheese in there. So that's basically it. Not a very enticing combination, but I enjoy it, and sooner or later I'll get tired of it and I'll switch to something else. For a number of years I was having bacon and eggs for breakfast. I forgot, I think I had some cheese along with it. I think it was a cheese omelet with some vegetables in the omelet. But then I got lazy and stopped cooking omelets. So, and for a while I was having sardines for breakfast. So that's basically what it looks like. I'm not a typical person because I'm not big on food. I'll have red meat if we go out. And in fact, last Saturday night, I split some steak with Joyce. I had to cut it real small because I'm not a big deal chewer. In the past, many years ago, when my wife was alive and we had a housekeeper, I would have hamburgers. And sometimes Joyce gives me hot dogs sometimes, which will substitute for the smoked salmon. So I'm not one to look at for gourmet food. How to get rid of the dawn effect of diabetes. Most of the time my sugar will rise in the morning 15 to 20 points without any food. Well, it's covered in the book. It depends whether you are type 1 or type 2 and how much insulin you're making. Sometimes we can give metformin or Avandia or Actose at bedtime, and we get rid of the dawn phenomenon. Sometimes we have to give a rapid-acting insulin on arising to get rid of the dawn phenomenon. Sometimes we have to give basal insulin at 4 o'clock in the morning. It all depends on the individual, and it's all trial and error. It's all common sense and trial and error. Well, that's it for our January 2020 teleseminar. see you again on Wednesday, February 26th. Have a good month and look forward to seeing you.